Hello, everyone. Thank you so much for joining our webinar this afternoon or this evening, depending on which time zone you're in. My name's Holly. I am the comms or the communications director at TheraPsil. I'm based in Toronto. We are live streaming on Facebook right now, and thanks to everybody who also joined us on the actual Zoom meeting. We'll give it a minute or so just to let everybody trickle in. We'll get started at about 7:02, 7:03. So thanks again for coming to our webinar this evening. And tonight's topic is, well, it's primarily for healthcare practitioners because we're going to be talking about, are your patients asking about psilocybin therapy? All right, and we have a wonderful lineup of speakers today. So I'm going to go let each of them introduce themselves. So we'll start with Spencer. Spencer, go ahead.
Thank you very much, Holly. My name is Spencer Hawkswell. I'm the CEO at TheraPsil, and I'm based here in lovely Victoria.
Okay, yeah, I'm Julia. I'm also in Victoria, and I'm the patient intake coordinator for TheraPsil.
Awesome. Thanks, Julia. Dr. Sean O'Sullivan.
Hi, everybody. Welcome. My name is Sean O'Sullivan. I'm an emergency room physician and a psychotherapist from Ontario. And I'm interested in this topic, psychedelic medicine, and in particular, psychedelic medicine for end of life. And you're all very welcome to this webinar.
Awesome. Thank you. And Dr. Neil Hanon.
Hello, my name is Neil Hanon. I'm a psychiatrist in Kelowna, British Columbia. I am on the training committee for TheraPsil and welcome you here tonight to a very interesting topic.
Awesome. Thanks so much, everyone. Really appreciate the time that you took as speakers to be here. And thanks to everybody on the line who joined us this evening. I'm going to pass it along to Spencer, who's just going to give a quick overview of who TheraPsil is for those of you who might be new to us.
Thank you very much, Holly. So TheraPsil is a group of healthcare practitioners. We were formed in 2019. However, our history dates back to 2017 when our founder, Bruce Tobin, submitted a Section 56 application for himself and his clinical team to treat patients with end-of-life distress with psilocybin. This was to be roughly modeled off of the Johns Hopkins study and similar studies that were conducted at NYU and UCLA. Back in 2019, we pivoted to start supporting patients and to become a nonprofit advocacy group. So that advocacy started with supporting 4 individual patients that were suffering from end-of-life distress. Those patients were here in BC, Ontario, and Alberta. And on August 4th, so 106 days later, after communications with Health Canada and sharing these and working with these patients and with healthcare practitioners to get these patient stories out, we were able to get access for these patients to psilocybin through Section 56. So while our organization is focused on advocacy, we also have 3 other pillars. One is education for healthcare practitioners. The other is education for the public, to teach them about the merits and limits of psilocybin. And the final one is research, so that we may work with our international and domestic partners on furthering research in psychedelics.
Awesome.
So thank you again, everyone who came here, and I'll pass it over to Sean O'Sullivan to talk about whether or not your patient might be a candidate for psilocybin.
Okay, Holly, I don't see my slides.
Can you see my screen right now?
I'm seeing you. I'm seeing the whole screen, but I'm not seeing the slides.
Oh my goodness. Sorry about that. Give me 1 second. I realized I'm not sharing my screen. Give me 1 second, everybody.
Failed kindergarten.
No. This is why we do tech checks, and I failed the tech check. All right, there we go. Go ahead, Dr. Sean.
Okay, so we're talking about psilocybin therapy here, and psilocybin is a psychedelic substance. And there has been 45 years of research, granted with a bit of gap in there, of about 30 years of research on psychedelics and psilocybin in particular for end-of-life distress. And so there are many other indications for psilocybin therapy, PTSD, addictions, etc. Most of you probably are aware of that. But in this particular instance, we're looking at patients who are suffering from end-of-life distress, existential distress with a terminal diagnosis. And this is not just taking a bunch of mushrooms out in the back. This is a professionally guided therapy session using psilocybin in combination with psychotherapy. And the psychotherapy is done before and after the psychedelic session, very little actually within the session itself. Psychedelic journeys are internal journeys. They are based on the kind of assumption that most people have in themselves all that they need to heal, even from such a significant problem as existential end-of-life distress. So we follow, to all intents and purposes, the Johns Hopkins protocol. And this protocol is actually modeled on a protocol that was developed many years ago in California by Stanislav Grof and other researchers who were working with psilocybin and end-of-life. Involves an assessment, first of all, to see if the person is suitable for psychedelic therapy, because there are inclusion criteria and there are exclusion criteria. Psychedelics are not for everyone. Most people can take them, but some people cannot. So there's first of all, an assessment. Sorry, can you go back to the other slide for me, please, Holly? I wasn't quite. There's an assessment of the patient and the situation and their past history. And then there is more detailed work looking into who they are, how they operate in the world, and how they're dealing with their illness and with the distress that comes from it. Medical oversight is very important, because there are some, not many, but there are some medical conditions and there are some psychiatric conditions that make psychedelic therapy not useful and not warranted. And when people are approaching death, of course, we have considerably more laxity with these parameters. And we work from guidelines produced by Johns Hopkins, but they are guidelines that we can shift and we can move if we have to. So for instance, the age that we begin with is usually 18, but if someone were younger or parents were happy to have this therapy, and if the patient was deemed suitable, we would treat somebody under 18. Okay, next slide, please, Holly. So this is the result of a study done by Ross et al. In New York in 2016 and Griffiths at Johns Hopkins. And the important thing about this is the rapid release of depression and distress, which was substantial and sustained. And the point to make about this, of course, is this is a single dose of psilocybin. This is not like taking an antidepressant every day of your life, which is a very different model and a very different way of thinking than practitioners are used to following in the present day, in the day of SSRIs and tricyclic antidepressants and all of those. To give one dose of a medication and have a substantial and sustained change in the person's mentation is really groundbreaking and ground shaking for us. These patients were subjected to intensive measurements of scales, the Hamilton Depression scales, all kinds of scales, though they were not just clinician ratings, they were the actual objective, to the extent that they can be objective, scales that were applied. This research, 2016, it was also, Hopkins did a follow-up study a number of years later and found that this improvement was sustained. And again, this is research that is building on and modeling the research that was done in the 1960s. Next slide, please, Holly. So these are our inclusion criteria. age over 18, as I said, it's not written in stone, and a terminal diagnosis. A terminal diagnosis means you're not getting out of this one, and no physical or psychological contraindications. The physical contraindications, you'd have to be pretty laid up before we would not treat someone on physical grounds. Psychological grounds, largely psychosis and schizophrenia and things like that are pretty well contraindications to psychedelic therapy. Under normal circumstances, that is, a person who is using psychedelics for a non-terminal diagnosis, suicidality and severe depression might be a reason why you would think twice, but in this instance, of course, it's not. They need to be on no contraindicated medications, and the chief medications, class of medications which are contraindicated are the monoamine oxidase inhibitors. There's a whole list of other medications which we're cautious about, but the monoamine oxidase inhibitors are the big ones, the big problems. And the patient has to be competent. The patient has to be able to understand the process and be able to give informed consent. And this really is no different than any other form of therapy that we would be planning to undertake. But of course, it's a little different when you're dealing with something that's so, in this era anyway, new and unusual and somewhat groundbreaking. So we take a fair amount of time with the patients to have them understand the psychedelic process and what they can expect from it and what potential downsides of psychedelic therapy is. Next slide, please. So any investigational medication, so a medication that we don't know a lot about, this is not going to be permitted in these studies because we can't put people at any greater risk. As I said, the monoamine oxidase inhibitors are contraindicated. Now, the psychoactive prescriptions are an interesting class. The benzodiazepines have no real dangerous effect on psychedelic work, although they certainly may blunt the psychedelic response. The SSRIs, TCAs, and SNRIs, the literature is mixed on these, and perhaps Dr. Hanon will say a little more about that, but these medications sometimes seem to enhance the psychedelic effect, and sometimes they seem not to. In terms of coming off these drugs, it's obviously better if you're not on any other kind of psychoactive medication, if the patient can get off them. But of course, any of the health practitioners here will be aware of the fact that benzodiazepines are a dangerous drug to withdraw from, and it has to be done extremely slowly in a stepwise fashion. And if they're done too quickly, the most prominent problem that one can get with it is a seizure disorder, but you can also get tachycardias and changes in blood pressure, all kinds of cardiovascular issues. There's probably no harm from a psychedelic perspective in someone staying on these medications if they cannot get off them, but it would be absolutely preferable if they could get off. The literature certainly is mixed on this topic because there simply hasn't been a lot of research on it. Next slide, please. Sorry. So we do a drug dosage at intervals of 5 half-lives. The half-life of a drug varies tremendously from one drug to the next. So this has to be done in consultation with physicians. You have to know the drug, you have to know the half-life, and you have to taper off it nice and slowly. Particularly true of benzodiazepines, but some people who've been on those drugs for years, it's extremely difficult to get people off them. It is ideal, but not necessarily, to have a drug-free week following the taper and prior to the psychedelic experience. Next slide, please. Pain medications, people in cancer have pain. Their last dose of a long-acting opioid, a sustained release opioid, should be at least 6 hours before psilocybin administration, and hopefully, again, not to be taken until 6 hours post. You have to be careful with drugs that have a cautionary therapeutic index. That is a drug where There's a very narrow range where the patient is therapeutic, and then you cross over that and they're into toxicity. And the drug that is most likely to cause that problem in this setting would be a fentanyl patch or something like that. But there's no evidence that I'm aware of that shows that opioids and psychedelics have any particular disastrous complications. Next slide, please, Holly, if I do have a next slide. Yes, chemotherapy, which is a big problem, hormonal therapy, radiation therapy, this is all acceptable. If the patient is tolerating this and tolerating those kinds of treatments very well, they can have psychedelic therapy. The usual course would be in a person who is taking, say, weekly chemotherapy. They would get their chemotherapy, say, on the Friday, and then the ideal day to do the psychedelic therapy would be on the Tuesday or the Wednesday. You have to allow some time to integrate the effect of the psilocybin. So you don't want to be taking your psilocybin one day and having a dose of chemotherapy making you feel totally wretched the next day. With regards to oral chemotherapy agents, they vary so widely that you would have to have a conversation with the treating oncologist and do your homework in terms of the drug reactions and the kind of side effects that can occur. Next slide, please, Holly, if I have one. Exclusion criteria are particularly the central nervous system. This was discovered quite early in the psychedelic studies, like back in the 60s, that people who had known CNS involvement, initially it was thought that seizures would be the problem. That did not turn out to be the problem. What turned out to be the problem was that a great deal of confusion arose in the patient when they were taking psychedelics in the presence of CNS involvement. Now, you might argue that psychedelics are a confusional state anyway. In fact, they're not. Once one knows the territory of psychedelics, they're quite manageable. They're stormy, but they're known and they're manageable. And it's quite different when the CNS involvement of a tumor metastases will give the kind of confusional outcome that happens, and psychedelics are not suitable. They can't have any evidence of a focal defect, anything that has a localized muscle loss or sensory loss. And then they can't be in any trial that is involving an investigational product because these drugs are new, their full range of action is not known, and whether they would be safe or not would not be determinable. Now, having said all of that, these are the exclusion criteria, again, that were used in the Johns Hopkins studies. And are they written in stone for us? They're written in settling concrete. They haven't quite settled fully into stone, but these are the template from which we work. Next slide, please, Holly. Severe liver dysfunction is a problem. Uncontrolled hypertension or active heart disease. There's no question that uncontrolled hypertension is an issue. Active heart disease fundamentally means also CNS disease, a TIA, a coronary event of some kind that happened within the past 6 months. If it's beyond 6 months and they're had a heart attack or a bout of angina or a TIA and they were stable, we would certainly consider treating them. Epilepsy is a down and dirty contraindication. We won't treat someone with epilepsy. Unstable diabetes is a problem because they're going to be 6-8 hours without food. Monitoring their glucose may be a problem. So unstable diabetes, brittle diabetes, people who've had a recent episode of hyperglycemia or hypoglycemia would not be suitable candidates. They need to be stabilized before we would consider treating them. And obviously, this last point just simply makes sense. Any significant medical comorbidities requires an individual physician assessment in detail of what's going on with the person and how they might or might not fit. Next slide, please, Holly. Schizophrenia and psychotic disorders, these have traditionally always been problematic for psychedelic research. And certainly we're not going to treat someone who is floridly schizophrenic or psychotic. The exception to psychotic disorders would be if it had been induced by a substance or by a medical condition, an encephalitis, a meningitis, something like that. Bipolar 1 disorder is a contraindication. Bipolar 2 may be considered after psychiatric consultation. And again, the medications would be a big issue with bipolar as well. Can the person be off them or on a reduced dose prior to a psychedelic session? Next slide, please, Holly. Okay.
This is over to me. Okay, so I just want to talk about what a Section 56 exemption is and how doctors and patients can apply for a Section 56 for their patient. So Section 56 is a section of the Canadian Drugs and Controlled Substances Act. It is approved by the Federal Health Minister, that is Patty Haiju. She is able to grant these exemptions to anyone on whichever terms she deems necessary. So in the case of our patients, that is on compassionate grounds. As these folks are dying, they have the right to die, and they deserve the right to try something such as psilocybin if they've tried other medications that haven't worked. So to be very clear, this is between the patient and the minister, and the doctor's role here is to provide a not recommendation or a prescription, but a confirmation that this patient is dying so that they may go to the health minister and request their own access. So this is a patient's right or a Canadian's right to their medicine that helps them through Section 56. So within this, it is about patient liberty, their right to choose their own medicine. And this has been well established with the access to medical cannabis, as well as safe injection. So that is the history and precedent for the Section 56s that have been granted and for future Section 56s that we hope to be granted. Next slide, please, Holly. So I want to quickly just talk about acceptance. And before I even get into this, I'll just note that over the past couple of weeks, we have had hundreds of emails come in from Canadians seeking access to psilocybin for a number of different reasons, many of which are end of life. In a recent poll that we did, this must have been 3 or 4 months ago, we asked Canadians completely unaided whether or not they would support medical psilocybin in our healthcare system. And 41% of them, top of mind, said that they would support this. The next question, we aided them. So we gave them a bit of the research that was done at Johns Hopkins and said that people who were dying that got access to psilocybin experienced decreases in their negative moods, anxiety, and depression. And this number skyrocketed up to 59%. And what this tells us is that Canadians are ready to accept psilocybin as a medicine in Canada, and that there is increased interest in these types of medicines. So that was an 18-point jump, and that is a lot. That was what you called a landslide. Next slide, please, Holly. So back to the reason that these Section 56s are being granted. It is best summarized, I think, by Bruce's quote here, Bruce Tobin being the founder of TheraPsil, that if Canadians now have the acknowledged right to die in Canada when faced with a serious illness and end-of-life distress, surely they should have the right to try a medicine that may help them want to live. So this is about, as much as there is research out there, these requests are being granted on the basis of compassion and patient rights. And I think that's it for me. Next slide, Holly. Awesome. So I'll turn this over to Julia, I believe.
Hi, thank you, Spencer. So I just want to kind of go through and just take you through each steps of this process, sort of from start to beginning. So just to kind of briefly echo the points that Dr. O'Sullivan made. Firstly, the patient just has to meet the requirements to be considered. So this is that they're a resident of Canada and received a diagnosis of a terminal illness and are experiencing end-of-life psychological distress, and that they're interested in trying psilocybin, and their emotional distress has not successfully responded to other treatments. So first of all, we'll get the patient, the application has to start from the patient. So they have to go to our website to the Get in Touch and Patients page, where they just put in an email and their phone, considering that they believe they meet these 4 requirements. And that will then send an email to us asking for a phone number and a good time to call. So then I will then just set up a 30 to an hour long conversation where I'll just go through this questionnaire, which will kind of go in more detail as what Dr. Sullivan sort of mentioned as our inclusion or exclusion criteria, just to determine whether they think they would be a good candidate to qualify for this process. The next step in this process is, if we do believe that they could be considered, is to go to their physician and go through this detailed patient intake criteria form, which will outline some of this inclusion and exclusion criteria, which a physician will go through of them. And if they deem them to be an appropriate candidate, they'll need to write a letter of support for that patient. We'll then connect them with one of our TheraPsil therapists, who will do their own assessment of the patient, and again, if they deem them appropriate, write them a second letter of support. And finally, the final step is to then come back to us at TheraPsil, and we will help them write a personalised letter to the Minister of Health requesting their Section 56 exemption, which they send along with their 2 letters of support from their physician and a therapist. Okay.
Awesome. Thanks so much, Julia. I am going to pass it along to Dr. Neil Hanon.
All right, hello everybody. So what I'm going to do is talk about liability and risk for healthcare practitioners. So what I'm basically talking about here are physicians. However, I think it pretty well applies to everybody who has a college that they are responsible to. So anyway, we'll get, if you can have the next slide, please. So where does psilocybin fit in terms of rules for physicians? So basically it fits as a complementary or alternative therapy instead of, or as an adjunct to conventional medicine. So the colleges actually have documents that talk about complementary or alternative therapies and what is required of physicians and practitioners, what are minimum requirements. And so the physician, if they're involved, can get into trouble if they don't fulfill the minimal requirements. So if we could have the next slide, please. So what's a complementary therapy? It refers to, and these are college definitions. So this is a College of Physicians and Surgeons of British Columbia, which is where I live. It's very similar to the one in Alberta, where I used to live, and it's also very similar to Ontario. So it's interesting that complementary and alternative therapies are basically more or less therapies that are not taught in the medical school, which is an interesting way to define it. But complementary therapy refers to any non-conventional practice of a range of medical therapies that fall beyond the scope of scientific medicine that is used together with conventional medicine. And alternative therapy refers to any non-conventional practice of a range of medical therapies that fall beyond the scope of scientific medicine that is used in place of conventional medicine. Now, it's very bizarre because psilocybin has a lot of research. And back when I was in medical school, we were actually taught that we use our medical knowledge and we use scientific literature, and clinicians were often the leading edge of medicine. However, college stances lately have said more or less that if it's not standard medicine or standard of practice, if it's out on the leading edge, then it falls into this category of complementary and alternative therapies. Now, unfortunately, the clinicians don't make the rules, the college makes the rules, so we have to follow the college rules so that we don't get into trouble. Next slide, please. So the college says, should a registrant choose to provide their patient with a complementary or alternative therapy, they must, One, conduct an appropriate and conventional examination and investigations in order to establish a diagnosis and basis for treatment. So if you were involved in a patient with psilocybin for end-of-life anxiety, it is incumbent upon you to do a full history, having a physical done by somebody, and have investigations at your fingertips, blood work, etc. Interestingly, you're not to delay or replace the use of an effective and proven therapy with a complementary or alternative therapy. Generally speaking, for end-of-life distress, what we're seeing is nothing that we have in conventional medicine really works as well as psilocybin does, or any kind of hallucinogenic type of medication or medicine. The patient needs to be we have to advise the patient unambiguously if the safety or effectiveness of a proposed intervention is contrary to the accepted views of the medical profession. And overall, psilocybin is contrary to the accepted views of the wider medical profession until they actually learn about it. And then they start realizing its value, and but it's just psilocybin and these medicines have been basically out of the public eye for quite a long time, for 30 years. But we have to tell them about the risks, benefits, and alternatives of all options so that the patient can give a proper informed consent. And that is important. The patient does need to give a proper informed consent. And so they have to be given the information and the details of the consent including the rationale for the alternative therapy, has to be explained, and it has to be documented. Everything, we are, as physicians, we're allowed to do unconventional things if we write down in the chart, if we show that we have informed the patient, that they are deciding themselves that this is something that they want. And even if it's unconventional, we can give a good argument, write it down, so that if there is any question from the college, they can read what our reasoning was. And we have to have a reasoning. Next slide, please. And it's important, they have to be satisfied that the proposed care and health benefits are safe, or at a minimum do not pose a greater risk to the patient than comparable conventional interventions, or to absence of treatment. And so these patients with end-of-life distress, they have a terminal illness, which is why this is being approved by the Minister of Health, because it is a safe treatment, and they are at end of life in any case. We do not want to hasten the death of any patient. We want to make the quality of their life that they have left improve. So if the patient chooses from an available treatment option and chooses a complementary or alternative therapy, and they've made it impossible for the registrant to discharge ethical responsibilities, then the registrant can terminate the patient relationship. And it's obvious every physician, every healthcare provider should never exploit the emotions, vulnerability, or finances of a patient for personal gain or gratification. So or gratification to get them on a list for end-of-life distress, for instance. It needs to be the right thing for that patient. Next slide, please. So they must set fees for non-insured services that are reasonable. They should not be exorbitant, and they must consider the patient's ability to pay when determining fee. Ensure ongoing assessment is conducted to evaluate the effectiveness and safety of the therapy. And this is a very interesting one where a lot of people could get into trouble, is when speaking public, provide options consistent with the current and widely accepted views of the profession, when interpreting scientific knowledge to the public, and clearly indicate when an opinion may be contrary to the accepted views of the profession. So as physicians, and treating end-of-life anxiety with psilocybin is not an accepted view, but there is good scientific evidence showing that it works. And so that has to be balanced whenever we are giving any information to the public. Next slide, please. Okay, so I just want to before we go to this, I want to go back to that last slide, and I just want to say some things. So this is when physicians are involved in the process of giving the medicine, sitting for the patient. Now, if you're doing therapy prior to giving, for the person getting the psilocybin, that's standard medical procedure, doing therapy for psychiatrists or anybody trained in therapy, and doing integration therapy after the session is standard care. And you would just be doing everything that you normally do with any patient that you are treating. The college issues end up surfacing if you are going to be the person who is helping the person during the session, because that's not standard physician therapy. Now, hopefully it will become standard physician therapy, but it's not currently. And that's where most people would run into the problem, because physicians are not prescribing this treatment. The health minister, the federal health minister, is allowing the person to have access to psilocybin. It's not a prescription, so we are not prescribing. Now, what I'm going to do next is I'm going to go into the situation with cannabis just as an illustrative factor or an illustration of where we might be heading with psilocybin therapy for end-of-life distress. So this is interesting. I really want you to notice the date on this document. It was revised February the 12th, 2020. So that is February of this year. Cannabis was made legal, I think somebody might correct me, but it seems to me it was November 17th of 2019 that cannabis was made legal in Canada for recreational purposes. Now, the college revised this from their previous documents, which are basically the same, February 12th of 2020. And so they are making statements about cannabis when it's used for medical purposes that is entirely different than how cannabis is used in the community, because it is legal in the community for anybody to smoke above the age of 19 or older. Okay, so I just want you to pay attention to some of the details in this, because what I want to get across, like I said, is that the colleges are very conservative, and we have to be very, very careful because of that conservative view, and that puts physicians under danger of losing their licenses if they don't realize that just because, for instance, cannabis is legal in our culture, that there are still all kinds of rules for cannabis for medical purposes. And if psilocybin becomes legal for medical purposes, there are going to be rules like this. So for instance, cannabis, not appropriate for patients who are under the age of 25, have a personal history of, or strong family history of psychosis. Yes, that makes perfect sense. Have a current or past cannabis use disorder. Have an active substance use disorder. Have cardiovascular disease. Pregnant or planning to become pregnant. Yes, yes. But carry on. Next slide, please. Now, this is all the medical documentation about cannabis, which is legal. The physician's given name, surname, business address, telephone number, province that they are authorized to practice, number assigned to the province, to the specific authorization, facsimile, the fax number, email address, patient's name and birth, address, and location which the patient consulted the physician, the daily quantity of cannabis expressed in appropriate units. This is legal. People can buy a whole bunch of marijuana if they want at the local marijuana store. Next slide, please. Okay, so I just want to wrap up a bit here and just say that it's really, really important for all documentation and to make sure that you just keep everything, your charts in order and so on. Otherwise, the college will come calling. Now, I'm not trying to suggest that you not be involved with psilocybin. I'm saying yes. Physicians, please jump on board. Let's get the people the help that they need, but you also need to protect yourself as a practicing physician, and you need to protect your patient. We need to protect this medicine coming in to be used. So I'm asking everybody to follow the rules. I follow the rules. Everybody just please follow the rules so that this doesn't go sideways. Thank you.
Awesome. Thanks so much, Neil. Very helpful and informative. I'm just going to pass it along to Spencer to kind of wrap things up, and then we'll also have a few minutes for questions.
Thank you very much, Holly, and thank you, Neil. So what's next? What are our next steps and how can we help you? Well, the first thing we're working on here is advocating, both continued advocacy for patients, but also advocating for healthcare practitioners. As you may have seen on our social media channels for the past couple of days, we've been posting videos from physicians and therapists. I think Neil actually put up his today. And we're sending messages to the minister and being very clear with Health Canada that while we do have hundreds of patients messaging us, we do not have hundreds of qualified physicians and doctors and therapists that are able to support these patients. Integral to training is getting these healthcare practitioners access to not only information about psychedelics, but also experiential time with the medicine so that they can explore altered states of consciousness themselves and build empathy, because it's absolutely integral in the teaching, and it has been the status quo back in the 1950s and 60s. I believe when these medicines were first being given to clinicians, it was actually advised that they take it on a moral principle, that it is the moral thing to do to understand the medicine before you give it to your patient. Perhaps that should have stuck around. We also want to make it clear that this is still the way that research is being carried forward across North America and Europe and elsewhere. Researchers are frequently using the medicine themselves before they would do any therapy with the patients. So absolutely, this should be a right for all of you healthcare practitioners to have access to a medicine that you're going to give to your patient. So please share the social media posts, comment to the minister. You can send messages to your MPs and to the minister yourself if you're a healthcare practitioner that would like to get access to psilocybin. I would certainly suggest it if you're interested. Secondly, if you or a loved one would benefit from psilocybin-assisted psychotherapy, please feel free to go to our Get in Touch page. It is advised that the patient reach out and they'll get put in touch with Julia, who you just heard speak. Also, if you're a healthcare practitioner that is interested, I realize that, and I actually noticed a couple names on this call here. We have been in contact with quite a few of you and will continue to keep in contact with healthcare practitioners as we plan to set up training, as it is one of our core competencies and pillars of TheraPsil. We hope to be able to educate healthcare practitioners, but surely we'll need to get access to psilocybin first. So please stick around, and we'll also be getting in touch with everyone again shortly just to provide updates. Finally, follow us on social media. Every social media like and comment really does help. That is the language that politicians use. They use Twitter, they use Facebook, they use Instagram, and this is advocacy. So certainly voice your opinions there. Finally, visit us on our website, www.therapsil.ca. It is vast. Much of the information here is on that website. And finally, if you would like to donate to what we are doing, we are a nonprofit organization and we survive off of donations. So if you could make any donation, that would be much appreciated. So now I'll turn it over to questions. Holly, would you like to send the questions out or would you like me to?
I can read.
You can go for it.
Okay, awesome. So let's give this one over to Sean, if you don't mind, Dr. O'Sullivan. So the question is, are magic mushrooms procured by the patients, or is it synthetic psilocybin? If it's the former, are the mushrooms analyzed for the psilocybin content? Oh, got you on mute there.
So yes, it's a very interesting question. Psilocybin comes in magic mushrooms, and there is also the chemical which is available, and the chemical is the chemical that is being studied, for instance, at CAMH in Toronto for a study of treatment-resistant depression. We're looking for a Section 56 exemption, and we can't get it for the psilocybin medicine itself, because psilocybin not only is not only legislated under the CDSA, the Canadian Drugs and Substances Act, but is also legislated about under Part J of the Food and Drug Regulations. And because it's in that particular location, a Section 56 does not apply. And it was actually moved in there by the Harper government precisely for this reason. So therefore we're using mushrooms, and neither TheraPsil nor the individual physicians can procure mushrooms for the patient because you're procuring an illicit drug. So the patient has to find a supplier themselves and get magic mushrooms. It's obviously not an ideal situation. The mushrooms are not analyzed by anybody for psilocybin content, and so it's sort of a bit like your grass. You know, you're at the mercy of the grower, and you get a good grower or you don't. I would say that mushrooms are usually pretty reliable when they come, so there's not particularly any need. And also, we plan to use fairly decent doses of mushrooms, like up in the 5 gram range. So you're not going to get no effect from 5 grams of mushrooms, even if they're not sparkling.
It's Neil here. Can I just add a little bit?
Please.
Yeah, so there are American people on, I can see on chat, but in Canada, spores for magic mushrooms are actually legal. And so patients can actually grow their own mushrooms if they have a Section 56 exemption and read a little bit on the internet, then they can actually grow their own mushrooms.
Thank you, Neil. I'd forgotten that twist, yeah.
Nice, thanks so much. Next question, this will actually be for Neil, Dr. Hanon. So at what point in the end-of-life journey is the treatment recommended? While the effects are sustained, may a patient need more than one treatment in their journey? So let's first part of that question first. At what point? I think as soon as they have a terminal diagnosis and they're having and they're struggling with it, and it would be useful. Now, when a person has a psilocybin journey, it may be useful to have a second one or a third one. But I would say, as a psychiatrist, that it's really important to integrate the information that the person receives from the session. And it may take, so it will depend on the trajectory of their illness leading to death. If they get a terminal diagnosis, but it's the process towards their death is going to take a couple of years, they could have a number of psilocybin journeys if they continue to help. Once they get a Section 56 exemption, they're allowed legally to have mushrooms, and they can have as many journeys as they choose. But of course, with us working with them, we would not suggest that they just use them willy-nilly. It's to help them with their process of how to get more life out of the last part of their life, and to get rid of the pathology that's holding them back, the anxiety that's holding them back. So, but each person will be slightly different.
and the treaters who are involved with that person need to take it all into consideration.
Awesome, thanks for that. This next question I'm going to direct towards Spencer. So Spencer, what's the anecdotal evidence that psilocybin works? Can you give us an example of an anxious person who benefited?
Yeah, absolutely. I think there's more than enough clinical research, but the anecdotal evidence is quite clear. We have lots of stories of people that have used psilocybin in the past. Specifically, we can point to one of the patients that's been treated with psilocybin legally, Thomas Hartle. And I think instead of going too far in depth into the explanation of his journey, I'll just post it in the side comments here. There's a YouTube video link to it. So I've just posted that now to everyone in the chat so you can see that. You can also, if you're watching this recorded, you can go to TheraPsil YouTube channel, and there you'll be able to see a session that we did, a similar webinar to this, where Thomas Hartle and Bruce Tobin talked about the experience where Thomas went through a psilocybin session and had some incredible results.
Awesome, thanks, Spencer. Okay, this is a medical question, so I'm going to leave it up to Sean and Neil to decide who's best for this one. So, are medications brought to therapy sessions in emergent situations where 5-HT2A antagonist, such as atypical antipsychotics, is needed?
Well, I'll start on that, be happy to, and Neil can add if he wishes. So this is a very important question, not just for dealing with psilocybin and end-of-life distress. This question speaks directly to the way that psychedelics are used and the mode of action of psychedelics. So in a normal standard approach that physicians are taught to use for symptoms such as anxiety and depression and nausea secondary to anxiety, some psychosomatic symptoms, the general aim of medicine is to provide some kind of medication which suppresses these symptoms. It'll never eradicate them if they're truly psychosomatic symptoms. You're not going to eradicate them with medications, but you provide something like a benzodiazepine or an antidepressant to settle down the patient and make the symptoms worse. Psychedelic work takes precisely the opposite position. If someone expresses anxiety or fear or terror or nausea in a psychedelic session, we would advise them to try and make it worse. We would advise them to die of anxiety, to die of nausea, to really get into it, because the notion would be that the idea is to bring this up into consciousness and clear it, to express it and to get rid of it rather than suppressing it. Because if you have an acute pain in your belly, I could give you morphine until you die, or I could take out your appendix. The same analogy is true in psychedelic medicine and in non-drug means of inducing non-ordinary states of consciousness also, such as breath work or any of the experiential techniques. This is precisely the approach that we take. So I would never give someone on Dancitron or Gravol settle down vomiting in a psychedelic session. I would bring them a bucket. The same applies to pain that they may have in their body. I would not give them something to suppress that. I would rather have them breathe into it, get the pain, allow the pain to get much larger, and then express the emotion that occurs at the end of this. The same applies to anything that might occur, even symptoms that might appear to you to be psychotic. If you let them run and let them complete themselves, then they have a chance of actually being cured, as opposed to giving some medication that will suppress the symptom and leave the underlying cause of what is being expressed intact in the psyche. Neil, did you want to add anything to that?
Yeah, these journeys have an arc to them. And I mean, this is where, you know, talking about Stan Grof's perinatal model, going from I don't know how many of you understand this, but or have heard of it. But let it be said, rather than going through all of this model, let it be said that you can start out in a pleasant place, go to a really horrific place, and then see that there might be a way out of this horrific place, and then end up in another pleasant place state again. And the problem is that if you stop the process, so for instance, risperidone is an antipsychotic medication and is a 5-HT2 antagonist. So it can actually stop a journey dead. But what ends up happening to that person afterwards is they end up getting stopped in a journey where all these horrible things were going on that weren't resolved. And if you allow the journey to continue on, those things actually get resolved. So like Sean was saying, the model is get them into it, get them into that space, get them to really explore that space, and because that space contains all the psychodynamic stuff that is causing them problems, and then they will come out of that into the resolution. And so we don't want to stop any of that stuff.
Thank you. Thanks for clearing that up.
The worst thing in the world you can do is have someone finish a session with something half in and half out. Miserable.
Okay. I'm mindful of the time, but we do have a couple other questions. So let me see here. Okay, so this is a good question. So TheraPsil is facilitating patients to apply under Section 56 of the Canadian Drugs and Substances Act for an exemption to receive access to what exactly? Is the Section 56 exemption for psilocybin or psilocybin-assisted psychotherapy? What are patients getting access to?
Spencer, do you want to take that?
Yeah, absolutely. So the patients are actually getting exemptions to psilocybin, otherwise known as psilocybin mushrooms, right? That is how they're going to get it. As Sean had said, because of some of the laws in the Canadian Controlled Drugs and Substances Act, actually it's specifically the Food and Drug Regulations, the patients are unable to get psilocybin from a drug manufacturer that might produce a GMP certified drug. So they are getting the exemption to possess, consume, destroy, and transport psilocybin, which means that they are protected from the law. As for the psychotherapy, there are no laws saying that psilocybin-assisted psychotherapy is illegal. So once that patient has their medicine, they may go wherever they want to take that medicine. They're not breaking any laws by consuming it or possessing it. So obviously this is not going to be the way that it is forever. This is very similar and a repeat of what happened with cannabis and the first patients that were given Section 56 exemptions from the law to use cannabis. So if you're asking whether or not it's access to therapy or making the therapy legal, the therapy is not illegal. So it's simply the patient's right to use the medicine how they see fit.
Thanks, Spencer. Okay, we'll do one more. So can someone speak to the use of mushrooms for treatment-resistant depression in a non-terminally ill patient? Where are we at with that?
Oh, well, I'll just say quickly, there was a webinar today at noon with Robin Carhart-Harris. I don't know if any of you tuned into that, but they're from Imperial College London. Carhart-Harris is currently the star of psychedelic research, and he has got a new study coming out in January, February of next year, which is comparing psilocybin to escitalopram in treatment-resistant depression. 2 doses of psilocybin over a 6-week period, 2 doses, as opposed to escitalopram daily for 6 weeks. And psilocybin is far and away better. It comes on much faster. Escitalopram is a relatively quick-acting SSRI, but psilocybin is like that day they're better. And the astonishing part about this, well, not when you know the science of it, but the excellent part of this is that the improvement with psilocybin is maintained in treatment-resistant depression. Neil, this is your bailiwick, really.
So I think that, I mean, there's old research too, and I think that, I mean, I think where we're at right now in Canada is we're just trying to get psilocybin for end-of-life anxiety because there's less of an argument about that one. And does it work in treatment-resistant depression? Of course it does. I mean, ketamine psychotherapy works in treatment-resistant depression. Every medication, every medicine that is hallucinogenic works basically for depression and anxiety. So it's, but there's a long road to go down to get all this as part of mainstream psychiatry. And I mean, we're on that road, and we plan on trying to get that happening.
Awesome. All right, so I'm just mindful of the time, so I think we're going to cap it there. But if anybody does have any other follow-up questions, please feel free to email us, info@TheraPsil.ca. I just want to thank all of our wonderful speakers. Thank you, Dr. Hanon. Thank you, Dr. Sean O'Sullivan. Thank you, Spencer. Thank you, Julia. And thank you also to the 41+ people on the line and a few others on Facebook who decided to show up tonight and take the time to learn about psilocybin-assisted psychotherapy. So thanks so much and have a great evening. Bye, everyone.
Thank you, Ollie.